Well, let's see. I guess I can do this one just as well. So I'm going to talk to you a little bit about the firsts at SIU, because there's been a number of them based on the various faculty and fellows that were here. Of course, this is the man who, as Nicole said, kind of started the whole program. So the very first academic plastic surgeon in Springfield, and the first academic plastic surgeon to wear pants like this. Never before had it been done. And there was a form of corruption where he would induce other people to wear the same kind of pants. Also the first, never seen before in public. Perhaps the first plastic surgery hockey game was done here on Zook's Pond. Now Zook didn't skate at all, but he was happy to put on boots and be the goalie, and then we could shoot pucks at him. But that's me and Dr. Wilhelmi, who also didn't skate and actually never moved from this picture. That was it. He stood right there. I don't know what to say about this, but I have gone around the country to various institutions, and I swear Zook's the first and only one to actually do stuff like this. Actually, in looking through the pictures of the archives, you wouldn't believe some of the stuff that was done here in the halls of SIU. Perhaps the first academic program to have a stripper in the halls of never before seen. The first Australian in Springfield was right here. The first woman president of the ESPS was right here. And the first, as Dr. Summers said, endowed chair of the school. Now this is something that is actually, in general, a responsibility of the Dean of Academic Centers, that they get endowed chairs so that there's a fund, a corpus, that their interest, you can provide financing for every division or department that's out there. Zook took it upon himself to say, we're going to have one in plastic surgery so that we can do education, research in perpetuity, given the interest money that comes from that. So he had insight, and it was with the help of Memorial, which also helped with all of this building that you're in right now. We'll give you a tour of that later on. And Dean Dorsey at the time. The first integrated residency program was during this time. And this is Mindy Hawes, as Nicole said. I'm right there in the back. I was the hand fellow at the time as she was about to graduate. The first plastic surgeon to have 3 daughters, academic plastic surgeon. And the first academic plastic surgeon to have a daughter that goes into plastic surgery. And so the tradition kind of moves on too. The second plastic surgeon only to have 3 daughters. There was something wrong with my wife. She couldn't have boys. It's not my fault. Also had a daughter, antibodies. She had antibodies. Wait, there's heckling going on here. And one of my daughters, my oldest daughter, went into plastic surgery as well. The first person to actually tell us the proper way to treat nail bed injuries was Al Zook. Back between 83 and 86, he took a look at all of his nail bed injuries and really defined and classified them and showed us what we should be doing with nail beds in order to get the right contour again and to restore anatomy, which is what we do in plastic surgery all over the body. He just did it in some part of the body that big, right there, and really defined this is how you do it. First person in plastic surgery to do that. I have a number of slides that were presented to me by Alan Van Beek, who was unable to make it here, but he kind of shows under the microscope here with Dr. Zook. Now the Dopplers they had back then were not the same type there. You can see the headphones that they have on, and that's Alan Van Beek trying to listen with the headphones, because that's where the sound would come from. Now obviously everyone in the room can hear the signal, but only that person wearing the headphones could at the time. This is actually one of the first dissecting microscopes that was developed in the lab that Alan Van Beek started. So microsurgery really came to the forefront. There's people doing experiments back in the 60s and such in California as well as in Asia. It became more prominent in the early 70s, and the first free flap was actually done at that time. By the late 70s, though, there was only a few programs around the country that had microsurgery labs to work in. And that's why actually in the early years, when Dr. Russell took over the lab, there's a number of Europeans that came over because they didn't have the microsurgery labs. So even in the early 80s, microsurgery was still in its infancy, really. But this is one of the first labs that did experiments. And one of the big things they were looking in was not only in vessel repair, but also nerve repair. And they did a lot of electron microscopy that actually showed this and showed the inner anatomy of the nerves. And even more than that, where the blood supply was to the nerves and where to put sutures in. And this is something that when Russell came back from working with Bertie O'Brien in Australia, that he was adamant that you put that suture in the proper place. It was the faculty from here, Dr. Russell and Dr. Van Beek, that really put together the first international microsurgery meeting. And there was a summit going on between the US and Russia at the time, and they all met at the same time and met with the Russian microsurgeons. And there they had this group of people that got together to show and share their experience. Bob, any comments on that meeting? You got to turn it on. It's a button. Someone's got to help them with the button. All right, I can come down. For years, I've been trying to get him to shut up, but now he can't speak. Are you working? There you go.
Yeah, so at the time, Ronald Reagan was trying to make the Soviet Union more of a democracy, and so he and Gorbachev were having summits about glasnost, and so it was an ideal time to try to get involved with them, and they wanted to do that. So we went to Petroshki's Institute in Moscow, and we went there 2 or 3 times, and it was sponsored by Sharp Point, who make the small microsurgery. And that's Rolf Schmidt there behind Alan Van Beek, and he's the owner of Sharp Point. There's Jim Steichen beside him. He was the guy that taught me hand surgery. There's Jim May in the front. There's Alan Van Beek and Bill Schwartz. Mike Jabolet, he's in the back. So we had orthopedic surgeons. These guys were all microsurgeons. Our first microsurgeons, and we met the Soviets' first microsurgeon. And it was kind of interesting because they had everything in the Soviet Union is centralized. So they had, for the whole Soviet Union, which is 11 time zones, they had 1 replantation hospital. Can you imagine what those guys, they probably never want to pay that? Because the whole country sent their replants to that hospital in Moscow, which obviously is not a great idea, but that's the way they do everything. So when we went there, we were supposed to stay in a hotel built by Arm & Hammer, which has all American plumbing and everything, nice hotel. But it was full because Reagan was there. We weren't allowed to stay there, so we got in the Soviet hotel. And these guys all brought their wives with them, and when we got to the hotel, in the morning, Joan Steichen's toothbrush had a cockroach on it. And she left. She went to Paris. You hear now all this going around talking to these guys, I'll be in Paris.
But the cockroach had clean teeth.
So it was pretty interesting. We turned on the water, we had hot water in the morning, all downstairs, no hot water. Coming back on 2 weeks. 2 weeks. So it's the idea again is a centralized system. So each building doesn't have its own hot water. It comes from the central place downtown underground, which is why the buildings are so cold in Moscow. And the heat's the same way. So in the winter, in the summer they shut it off
be Dr. Datash Levy,
I
right?
don't know how you do that, but he did.
Wow.
So it was an interesting time in plastic surgery and microsurgery.
Great, I just meant for you to say one or two things. So another thing that Dr. Van Beek did was one of the first. This is a child with bilateral upper extremity amputations. And at that time, they actually, I believe that Van Beek and Russell were looking at this and saying, we don't know if this is even possible, and plus the scapula had been ripped off as well. And they called back to Dr. Bennett in Indiana. They talked with Dr. Kleinert in Louisville, and they said, what would you do with this? And they said, we'd probably give it a shot. And so he sent this, and this is the young lad with his arms back on, and with Harold Kleinert and Bennett and Zook all saying we should do this. Well, I think it was the right thing to do. And there's Russell as a chief resident after they had finished that case. That's the operating board in the back at Memorial. You can see how they used to do it back then, just write things down there. He doesn't look that tired, though. And of course, this was in the local newspaper, and if I write down, I get focus on that, it was about a 13-hour operation, which actually, given that bilateral upper extremity, is not that bad at all. They had the orthopedics. Dr. Shannon Stauffer was the very first orthopedic chair. And with, of course, I said Van Beek and Russell were working on that case. Very first pediatric scalp replant that was done, super probably microsurgery, to the point where it's very difficult to even see what's artery, what's vein, so you send a biopsy off of the vessels to pathology and let them define which one's the artery and the vein. But a very small area, there was actually, you can see how big of that was. Must have been a part of a presentation that Alan gave as he kind of delineated the size of the vessels that they were about to anastomose. And sure enough, it went on to survive and age. And the very first, probably, heel replant by Dr. Van Beek here. They were very aggressive back then, very interested in microsurgery, but it worked, finding small vessels, the artery and the vein, to hook that back up. And of course, there's the spear, which I believe is the first time that the pannus was skewered with one big rod. You can see the number of people in the operating room there. And Bob, you've never seen that many in yours. There's only one, maybe two people in there. But look at all the people, and this is what they used to do with the spear. Of course, Russell took that over, and it became known as the Russell rod with time. I don't know if this is really true, but Alan believes this is the first external fixator from homemade means there. This looks like methyl methacrylate that was actually pieced together to be an external fixator and probably a really comminuted mandible fracture. Done with the chief resident at the time, as well as the oral surgeon in town. Russell had a number of, he was very interested in various flaps and extending the indications and possibilities as to what we could do. And he believed that by doing some studies in the lab that you could extend the pectoralis flap. It was once said that you cannot go beyond the muscle to take a skin paddle, because that paddle would not have the appropriate blood supply. So again, following some experiments in the lab to prove that perfusion could be made, he found that if you took the fascia of the rectus abdominis muscle along with this, it would actually perfuse that distal aspect, and you could have an extended flap that could be used instead of microsurgical techniques as a pedicle flap. Along those lines, he popularized, you'll have to correct me if I'm wrong, you didn't describe this, but popularized it?
John Franklin found it first, but he didn't look at the nerve function. We identified the fact that this is the one flap that had a nerve in it. The end of the axillary nerve was there. So you could make the sensate flap out of it. So we used the resonance to figure out where the sensation was when we had them put pins,
Now there's an idea.
you guys had it made, yeah.
All the pins out there? All right. So I have some pins in my office. See how easy it is these days? So there's the design. By the way, back in 1975 as well, they hired Gary Schnitz, who was their medical illustrator that would draw these various diagrams for them. They did a lot back in 1975. But you could see the outline of the deltoid flap, and it was used for larger areas. Pretty much the whole deltoid area could be used for that. And then skin graft the donor site. And this is one of Russell's case, one of the first cases with this, and he was a Mountain Dew fan. He was also interested in spare parts, and throughout his entire career, he was involved in taking a look at the body parts that were amputated and see if they could be utilized for other aspects of reconstruction. For instance, in this lower extremity, where much like Alan Van Beek did the heel itself, Russell used that as a spare parts to preserve length and thereby preserve the type of prosthetic, or improve upon the type of prosthetic that this young lad and now man could utilize. Perhaps not the first done in the world, but the first done in North America is an ectopic hand transfer. And this is, in this case, this is where, Bob, you're going to explain this one again as to what happened here and what you did.
Okay, this guy was a farmer, and he was using his corn picker, and he got stuck. And so when your corn picker gets stuck, what you should do is turn it off and get around and take them. And anyway, he didn't, and he grabbed his clothing and pulled his arm into it. So he had his left arm above the elbow. So then he tried to reach in with his right hand to get the left arm out, and that one got caught too. And so we had that arm, and then we had the other hand, and he was in the rollers, and so in the palm it was only about that big, burned and squashed. So we tried to put to take the fingers off. There it is right there. So we tried to take the fingers off and stick them on the end of the stump. But unfortunately, that's what we tried with some grass, but they didn't make it. And on New Year's Day, the other side got an infection, the arm we put back on, and blew out the vessels. So now we had a perfectly good hand on the left side and no hand on the right side. So on New Year's Day, we missed all the football games. We took the hand and put it on. And again, I had to kind of make this up, because really extension channel, flexion channel. Anyway. So we made that up. We didn't make a single bone for him. We put the radius to the ulna and the ulna to the radius. In my mind, that should still work, but don't do it. It doesn't work. You don't make the suplex. So we had to go back later on and make the single bone for him. But anyway, this guy went on to do really well, and he had a family, and he has a prosthesis on the other side. And if you ask him, which one you like better, he overwhelmingly says that he writes with that hand, and he farms with that hand, and so forth. Anyway, that was the first cross-hand transfer in America, but it turned out that somebody in France had done one. I didn't know that. It hadn't been written about, but anyway.
So, and actually, then there was another one done here. Not the first, though, but this one was done by Dr. Brown now, some years later. Same idea, both extremities. You can see the mutilation of the left hand there, and then the right hand. And that's Dr. Brown's patient. So it looks kind of funky, the way they actually drink that coffee with that upside-down hand. What some people may not realize is that we are also the first institution ever to do a deep flap in Illinois. And that started back around 1997, I think was the first one that we did here. And it was already being popularized out of New Orleans and in Belgium, and first described by Koshima back in '89. But it took a little while to gain popularity around the country, and so used for breast reconstruction for the most part. I've actually found in some folks with a rather large body habitus that rather than taking an ALT when you need a lot of tissue, that this flap provides a lot of tissue with a better donor site than the shark bite that you can take out of the thigh. And in this particular case required a functioning muscle transfer, which had been well described before, but it was the idea that the deep flap was actually something that was unique to this institution, at least in Illinois. So then, when I was in Boston and working with Julian, he taught me about prefabrication, which is the idea of just introducing a new blood supply to tissue that really didn't have that axial blood supply. And this is one of the cases that I did. I was there for the second part of this particular case. So this is his patient that he had been treating with this hypertrophic scar that was painful, and he wanted to remove that, but also restore it with like tissue. And he had done this prefabrication where essentially taking the superficial temporal vessels and placing it down on top of a tissue expander. He taught us about using Gore-Tex around a vessel so that when you come back a second time and you go to move that pedicle, you don't damage that. It's protected by the Gore-Tex. And that you can expand that and then move that flap as an axial flap. And the vasculature is incorporated into the overlying tissue. So, and he had learned that or started that work in Australia with Wayne Morrison and published a lot of work then subsequently in Boston. So when I got back, the idea of tissue expansion and how the vascularity arborizes into the surrounding skin. There was opportunities at times in the very first prefabricated off-the-shelf tissue. This is going to be Integra, and I have no disclosures and no financial interest in that. But this was a gentleman had an 82% total body surface area burn, had an anoxic brain injury as well. 2 years later, he comes back after all the grafting was done, and he had all these contractures. His biggest problem was that his wrist was rubbing on his chest, causing a painful ulcer. And the way to treat that was to extend the elbow, if you could just get the elbow straight. But the donor sites were very limited. So what are we going to do with that? Luckily, he had a thigh. He had one thigh, so an anterolateral thigh flap. Of course, that's what we're going to use. So I elevate that, and I cut around the edge of that. And in front of our eyes, it starts turning blue. Like, that's not fair. I haven't even elevated the flap yet. That's not fair. So we decided we're going to wait. We're going to delay this and just see. I couldn't find any superficial veins around there. The next day, it looks like this. And sure, you're thinking, okay, well, that looks like one of Russell's flaps. That's okay. But that's not good. But as we got rid of that, there was a vessel at the base of that that we dissected down, and sure enough, the descending branch of the lateral circumflex femoral vessel pedicle is there. What the heck? I was just sabotaged on that one. So now, the only donor site that I had, that I thought I had, was this one. And we thought, what if we prefabricate this? What are we going to lose? It doesn't work, and we skin graft that we were going to have to do that to the thigh anyway. So we took a piece of Integra, so this is an off-the-shelf synthetic material, and we take the pedicle, again the Gore-Tex to protect the pedicle, it's placed between the muscle and the Integra, and then we let that mature for about 3 weeks, take the silicone off, put a skin graft on there. 2 months later I came back, that's the outline of the defect that I would need. Raised it up just at the level of the muscle and the Integra, so it's a very thin kind of flap. That's the defect in the antecubital fossa that you will expect once you open that up. And there's the flap. You can see when we went beyond the Integra, it looked rather pink, or rather purple. That was interesting. That part actually granulated over, but there's his prefabricated off-the-shelf free flap. And that was the first that was ever done in the world. That was based on the work that Julian had taught us. So we went to the lab, we started looking at more of this stuff and said, I'm interested in patients like this, in the burn population. How do we actually prefabricate, say, an ear when you don't have the superficial temporal fascia that's there anymore? So we created an ear in the lab like this. Well, Chow had described this as on Time magazine, where he created an ear on a little mouse there. But this is the first time that one had been on a pedicle. The ENT folks at the same time said to us, hey guys, if you're doing that, and there's the ear, kind of looks like an ear. What if one of your patients that you treated in the burn unit who has a horrible inhalation injury and now has had 30 some odd operations, tracheal resections, allograft put in there, pull-up procedures. We're at our wits' end. They keep getting stenotic, and they're losing their airway. They're going to have some sort of intrathoracic means of getting an airway. Could you create an airway? Don't know. Don't know if you could do this. So we went to the lab, just like Russell had done years back in the lab, go to the lab, fix a problem, and go back into the operating theater. And we did the same thing, only we used the sternocleidomastoid muscle for that. And we created this. 4 weeks later, we opened this up and we look, oh my gosh, it sort of looks like a trachea. Same principle. So we went back, we used the descending branch, lateral circumflex femoral vessels, and that was going to be our pedicle. Took a little cuff of muscle, just as a little capillary bed for the artery and the vein. Took the ribs, got a silicone block, wrapped that around there, used a longitudinal strut so it doesn't collapse on us. Plug it into the thigh. Immediately afterwards, and then about 2 months afterwards. I'm not really sure how long you need to wait. It's probably too long. 2 months? Weeks?
8 weeks.
8 weeks. So there it is. We take the silicone off, the suture's there, and we're looking inside that. Now I took extra skin. The guy had 30-some operations. I might need some extra skin. So I took that on top of that, and that was perfused. What was fun, though, is afterwards, a scope was done, and this is looking down the trachea, and you can't tell what is the resected and reconstructed trachea. So that's the first time in the world that someone has done a prefabricated trachea on the thigh. Well, that's kind of fun. Where else can you do this? So we did it for the mandible, and this Andy Gump kind of deformity, because it had multiple operations, the same idea, pedicle, this time cadaveric bone. And we created a trough in that, and we put that in there, and there's his pedicle maturing, doppled out. You can hear it all the way through there. And the video doesn't work here, but it shows that there's capillary refill all around that. So then we plug that in. Now, he had umpteen losses of various fibulas and such like that. So I knew I couldn't go into the neck, so we also had to take a big vascular vein graft and go down to the internal mammaries in order to get up there. He needs a little bit of work, but it survived. So can't judge me on how it looks right now. But the pedicle, the cadaveric bone, was actually revascularized, as was the skin on top of that. And that's the first time that's been done. A couple other things. So the first at SIU. The first editor of the journal Hand was Elvin Zook. So we were the very first place. In fact, SIU still maintains the editorialship of that journal. As was mentioned by Dr. Summer, the first integrated program, we were amongst that same group. Actually, Zook was on the committee that designed the integrated program. There's Mindy Hawes. We had the first embedded hand fellow. So this is something that's very new. So now within our 6-year program, you can actually finish all of your plastic surgery in 5 and do an embedded hand fellow. There are now 2 programs in the country doing that. WashU is the second one, and there are 4 more that have applied to do that as well. And so you can complete and be CAQ certified within the same time frame. The way that started was we're taking a look at the numbers. The minimum numbers that you need in plastic surgery and hand cases are 122. That's it. After 6 years, you only need 122. The minimum number, if you took a look from 1917 and 2018, hovered around 237 to 209. SIU is at the maximum, 1,536. So I thought, why the heck could these folks not write a multiple choice exam and get their CAQ exams and be a part of the Hand Society? That was the start of it. And we got it. We got it passed through the RRC and through the American Board of Plastic Surgery. So, the various cases, and this is Danielle. She's the very first embedded hand fellow as well. She did a microsurgery fellowship after that and is now down in Florida. Actually, she's down in Tampa. And there's various other programs going on now. Cleveland Clinic has started one in aesthetic surgery. There's craniofacial microsurgery, gender and breast, also starting in embedded hand fellowships. So those are some of the things that we did. I may have missed a number of things. And certainly people have left here in the residency and gone on to do some amazing things and firsts of their own. So, but thought I'd share that with you. So there you go, the firsts. So now I'm going to bring up Elof Erickson.